Hi, my name is John Mite, and I'm going to talk about complex implicity and Hirschsprung disease. This disease is a motor disorder of the colon caused by the failure of neural crest cells, the precursor of enteric ganglion cells, to migrate completely during intestinal development. The resulting ganglionic segment of the colon fails to relax, causing a functional obstruction. In the majority of the patients, the disorder affects a short segment of the distal colon and rectum, with the transition zone in the rectus sigmoid. In other patients, the ganglionosis involves longer segment of the colon, and in rare cases, the entire colon and part of the small bowel may also be involved. This disease occurs in approximately 1 in 5,000 live births, with an overall male-female ratio of 3:1 to 4:1. When the entire colon is involved, the sex ratio more nearly approaches 1:1.
Hirschsprung's disease is a condition that primarily affects the large intestine or colon. It is a condition that involves what we call ganglion cells, or the cells or nerves that allow the colon to relax. And so the stool is getting backed up behind the segment of colon that is not relaxing. What are the signs and symptoms of a patient that might have Hirschsprung's disease? The first thing that we look for is the failure to pass stool or meconium in the first 24 to 48 hours of life. Often these patients also present with abdominal distension and potentially also vomiting.
Well, the application in medicine, Hirschsprung disease is suspected based on clinical features described above, usually supported by contrast enema or anorectal manometry. The diagnosis is established by rectal biopsy. The absence of ganglia on the suction biopsy confirms the diagnosis of Hirschsprung disease, provided that the sample is adequate, meaning that the biopsies were obtained in from the correct form and site and contain at least a small amount of muscular mucose. If ganglia are seen in a properly performed suction biopsy, this disease is virtually excluded. And the mainstay of treatment is the correct surgery.
Children born with Hirschsprung disease often suffer from enterocolitis. The best method for treating this condition is by flushing and emptying the colon with fluid, which is called rectal irrigation. You'll need the following supplies in order to perform a rectal irrigation: 2 small basins, a 60 milliliter syringe with catheter tip, and a silicone catheter. If your child is under 1 year old, a size 16 French Foley catheter should be used. And if your child is over 1 year old, then you'll need to use a size 24 French Foley catheter. You'll also need water-soluble lubricant and normal saline. Start by warming the normal saline. We recommend sitting the bottle in a sink of warm water, then testing the temperature of the saline on your wrist to make sure it isn't too hot. Pour the warm saline into a small basin, then draw up 10 to 20 milliliters using your catheter tip syringe. Position your child so they are laying on their back with their knees bent to their chest, or if they are bigger, with their knees bent with feet flat on a surface. Place the empty basin next to your child. Lubricate the top 2 inches of the tip of the catheter and insert it into the rectum. Gently push the catheter so it follows the curves of the colon. Insert the catheter approximately 4 to 6 inches. Pause for a moment to allow any stool or gas to drain out the catheter into the empty small basin. Connect the syringe to the catheter and inject the 10 to 20 milliliters of saline. Disconnect the syringe and let the saline and any stool drain into the empty basin. Advance the catheter about 1 inch and repeat the process until the discarded fluid is clear. Do not advance the catheter further than the wide divider port. It is important between each injection that fluid drains into the basin. If the amount of saline you inject into the rectum is more than the amount of fluid that returns to the basin, then there is extra fluid in the rectum. To drain the extra fluid, try moving the catheter in and out while twisting. If fluid still does not come out, then the catheter may be clogged. Pull out the catheter and flush with saline into the basin before reinserting. If you think there is still fluid in the colon, you can reattach the syringe to the catheter and very gently pull back on the syringe to draw out the fluid. Do not pull back on the syringe if you feel any resistance. It's important to record the amount of saline injected into the rectum and the amount of fluid that comes out. In a good rectal irrigation, the amount that comes out is larger than what went in. Once the drained fluid is clear, remove the catheter from the rectum and wash your supplies with soap and water, then set out to dry. The supplies are reusable. For more information, please.
Well, now let's talk about the pros and the cons. After surgery, most children are able to pass stool through the anus, and most children with Hirschsprung disease gain weight, grow, and thrive after surgery. Rarely, a child may need a second pull-through surgery. The cons, the possible complications that may improve with the time are diarrhea, constipation, leaking stool, delays in toilet training. The children also may also continue to be at risk of getting a bowel infection. It's called enterocolitis after surgery, especially in the first year. Now, the issue at play in Ecuador. There have been 41 cases with Hirschsprung disease and 41 controls from the Pacao Ortiz Pediatric Hospital in Quito and the Machache Hospital in this year. In conclusion, Hirschsprung disease is a common cause of neonatal bowel obstruction. This neonatal who become symptomatic during the first few days of life typically presents with failure to pass meconium, abdominal distension, vomiting, and other signs of intestinal obstruction. Most can be non-operatively with gastric drain and rectal irrigation while awaiting the results of the contrast enema and suction rectal biopsy. Rarely, surgery will be required when the obstruction does not improve. Thank you.